Hi, everyone. I think people are still coming. Okay, no, we're done. All right, so assalamu alaikum, everyone. My name is Saleha, and today I'm going to be giving you guys 3 sessions, inshallah, starting with metabolic defects in amino acid metabolism, and then we're going to move on to nucleotide metabolism 1 and nucleotide metabolism 2. All these lectures are reasonably short, but they're really important, and Miss Dr. Henna actually likes to ask very specific questions. So as I go along, I'll try to make sure to point out which things she likes to ask about, or which details that you need to remember. All right. So starting with metabolic defects in amino acid metabolism. Okay. All right. So we're going to be covering these 3 disorders first: phenylketonuria, then albinism, then alcoptinuria. Then we'll come to maple syrup urine disease, methylmalonic aciduria, and propionic acidemia. These are also called organic acidemias. Then we'll come to homocystinuria, and we'll end with a few questions, inshallah. So first, what are inborn errors of metabolism? The metabolism in what happens is there's a gene, that enzyme. When that ends up getting distorted, maybe it becomes defective. In some cases, the enzyme even may be absent, or the amount of the enzyme may be insufficient. So these are all, categorized as inborn errors of metabolism. So what happens is they can be a total loss of the enzyme or a partial deficiency in the enzyme. But either way, a lot of the times, because these pathways are so complex and they have so many steps, when there's a defect in any enzyme, that often leads to accumulation of the product, or either the substrate that the enzyme uses, or some product somewhere. And because of that accumulation, you end up with a lot of dysfunction in the body. It can be mental retardation. It could be sometimes the liver enlarges, sometimes the spleen enlarges, depending on what the product is. Different organs in the body are affected, often by accumulation of a certain substance. All right, so first we're starting with phenylketonuria. So phenylketonuria is important because it is the most common inborn error of amino acid metabolism. And it's caused by an accumulation of phenylalanine. Hold on, let me just turn on my pointer. How do I do that? Okay, can you guys see this? Yeah. All right. So PKU is caused by an accumulation of phenylalanine. And why does this happen? So let's go through the reaction first. Phenylalanine is converted into tyrosine through the enzyme phenylalanine hydroxylase. Now, this enzyme needs a cofactor. Without this cofactor, the enzyme cannot produce its action. This cofactor is called BH4, or tetrahydrobiopterin. So when there is a deficiency in the phenylalanine hydroxylase enzyme, phenylalanine is not converted into tyrosine, right? But this process can also, be affected if there's a deficiency in BH4. Unavailability of BH4 can also, prevent this reaction from occurring. So you're looking at deficiencies of 2 possible enzymes here. One is phenylalanine hydroxylase, so this enzyme here. And the second is the enzyme that produces BH4, and that is known as dihydropteridine reductase. So an enzyme in dihydropteridine reductase or phenylalanine hydroxylase deficiency, and deficiency in either of these is going to give you phenylketonuria. Now, what happens in these patients is you get accumulation of phenylalanine, which then results in a lot of side effects, as we'll see. And there's insufficient amount of tyrosine in the body. Now, there's certain products as well which these patients can avoid, such as aspartame. Aspartame is, something that produces phenylalanine, and it will contribute to an excess of phenylalanine in the body. But what actually happens? So because there is too much phenylalanine, this now gets converted into all these phenylketone products. So you have, phenylpyruvate, and then phenylacetate, and phenylacetate, and all these basic other things, which will then accumulate in the urine and also produce side effects in the body. Side effects including mental retardation, also hypopigmentation. Why? Because tyrosine is not being produced, and tyrosine is necessary for the production of melanin. Melanin is what gives your skin melanin because of a decrease in tyrosine, but a deficiency in tyrosine, the patients will end up with hypopigmentation. This means that they're going to have a light-colored hair and light-colored hair. And okay, someone let me know that I will try and avoid. Is it better now? Is the audio better now, guys? All right, so I hope. Okay, great. All right, so one sec. All right, so as I was saying earlier, because there's a decrease in the melanin that's produced, this results in pale colored hair, so blonde hair, blue eyes, light colored skin, and these patients will typically kind of look like, patients with albinism, except they don't have, the other deficiencies associated with that. Now, it's really important that newborn babies are screened for phenylketonuria because this is a disease that only presents, maybe sometimes it can be when it's caught earlier in age, then you can prevent symptoms from developing by treating these patients earlier on. So there won't be an accumulation of phenylalanine, and these patients will be able to overcome kind of the symptoms. Okay, next is albinism. So albinism is also caused by a deficiency of tyrosine, but this time it's caused by a different process. So earlier in phenylketonuria, the deficiency was in either phenylalanine or in dihydropteridine reductase, which is what was producing BH4. Now in this case, we have a deficiency in tyrosine. Not here. Okay. And sorry, tyrosinase. Tyrosinase is the rate limiting step of the conversion from tyrosine to melanin. So when there is a deficiency in tyrosinase, again, you don't have melanin, and these patients will also have blonde hair, pale skin, blue eyes, sometimes even absolutely no pigment. So they can even take on this, reddish color. And yeah, that's all you need to know for albinism, actually. Next, coming to Alcoptinuria. So Dr. Henna, I think, wanted you guys to understand the process of how this disease comes around, but I wanted you to understand what is actually happening before I show you the diagram, talking about this diagram. So what happens here? This is a rare metabolic condition involving a deficiency in yet another enzyme called acid oxidase. And this causes accumulation of homogentisic acid, or otherwise known as HA. Now, this is a product that is produced in the degradation of tyrosine. Okay, all right, so here we're looking at the tyrosine metabolic pathway. And tyrosine is converted into first hydroxyphenylpyruvate, and then it's converted into homogeneous acid. And a deficiency of this enzyme. Hold on one sec. There's a slide that's missing. Where did it go? There it is. Okay. We'll come to that. I will put this here. All right, so the two symptoms, or the two things that actually happen. The first is an accumulation of homogentisic acid, or HA, which produces a black pigment. Now, this black pigment can either come out in your urine, or it can be deposited in the cartilage and collagenous tissue. And this black pigment is essentially just the homogenesic acid, and then it gets oxidized to become black. And this is what it looks like. So here's a patient with Alcoptinuria. As you can see in their eyes where they have, collagenous tissue, there is a deposition of this black pigment. It's also known as Akronosis. It's also seen in the fingernails and in any other place. It can also be seen in the ears, for example. It's seen in various places. Another thing that happens to these patients is they get a lot of arthritis. So these are two things. Now, the fact that they're also turns black is a carrot becomes oxidized and it produces this. And this is what that looks like. This is what the urine of a patient with Alcoptinuria will look like. This is a sample that's been setting for 2 hours. On this side, you have a sample that's only been setting for 15 minutes. But you can tell that there is this black pigment depositing at the top. Now, this is the vertebrae of a patient with Alcoptinuria. Again, there's this deposition of this black pigment here. So what happens in these patients? There's black deposition in their tissues, but on top of that, their urine can contain this black deposit. So when mothers first bring their babies to the hospital, they sometimes say, my baby's urine becomes really dark, or the diapers, after the baby has urinated, the diapers become really dark, and it's concerning. And so sometimes that can be the characteristic presentation symptom in these patients. What happens is their urine becomes dark, and there's no other symptoms until later in life. But often when a mother notices this, she brings her baby to the hospital. How do you treat these patients? You give them a diet low in phenylalanine and tyrosine. You are basically preventing an excess of phenylalanine and tyrosine. So this will prevent levels of HA being deposited in the body tissues. Now, while this condition is not life-threatening, for example, phenylketonuria was life-threatening. Remember how phenylketonuria causes it can cause mental retardation and CNS symptoms, etc. This is not like that. You don't have such life-threatening symptoms. However, one thing that does happen is these patients get very bad arthritis. So sometimes, this can be very crippling, especially as the patient, gets older. Their arthritis can be more and more severe. All right, so this is a slide that kind of covers everything that we just went over, the 3 diseases of albinism, Alcoptinuria, and phenylketonuria. And it basically describes how each of these, occur. Phenylketonuria was a deficiency in phenylalanine or a deficiency in BH4. Albinism is a deficiency in tyrosinase, which converts tyrosine into melanin. And then Alcoptinuria is a deficiency in homogenesic oxidase. All right. Now coming to maple syrup urine disease. This is another autosomal recessive disorder. It's also very rare, but it's easy to pick up on. Why? Because the urine of these patients has a very significant, unique smell. It smells like maple syrup or like burnt sugar or something in between. So what happens here? There is a deficiency of the branched chain amino acid enzyme, also known as alpha keto acid dehydrogenase. So branched chain alpha keto acid dehydrogenase, BCKD. What does this enzyme do? It decarboxylates keto acids or of the branched chain amino acids. So which are the branched chain amino acids that we're looking at? Leucine, isoleucine, and valine. So because the keto acids of these amino acids are not being decarboxylated, they accumulate. They accumulate in the blood, resulting in symptoms. Remember how earlier I said that all of these diseases are caused essentially because of accumulation of something or the other? So what happens here? There is the absence of branched chain alpha keto acid dehydrogenase. So there's impaired degradation of these 3, leucine, isoleucine, and valine. And you end up with elevated alpha keto acids in the blood. Now, what are the features of this disease? So ideally, you're going to have a baby who's not going to say that my newborn is not feeding well and is vomiting a lot of what I feed my child. And other things could also be lethargy. So the baby is just very tired, loss of consciousness. Ketoacidosis, again, why? Because there's accumulation of keto acid. Changes in muscle tone, so dystonia, weakness, and then also neurological problems like and coma. There's more like maple syrup, isoleucine, and maple syrup. There is just that accumulation of. Sorry, I think my internet is a bit laggy. I hope it's better now. Just to check, can you guys see and hear? All right, great. Okay. Perfect. Where were we? All right, so yeah, as I was saying, it can be severe. Now, here are some enzymes and coenzymes and cofactors that are used by BCKD. Dr. Hannett likes to ask about these, so it's important that you remember them, although it's not as important in the actual disease process, but it's important that you remember these enzymes and cofactors. So the way she kind of, she gave us this mnemonic to remember, tender TLC, important thing to remember is that sometimes these patients can be supplemented with thiamine pyrophosphate, and that may ease your disease. This again is only, it only helps treat some patients, but giving them a cofactor that this enzyme requires can sometimes slow the progression of their disease. All right, now coming to methylmalonic aciduria and propionic acidemia. These are known as the organic acidemias. All right, so what happens here? So these are inherited genetic disorders. And again, there's impaired metabolism of fatty acids and proteins. But in this specific lecture, we're only looking at the protein aspect. What happens here is there is a deficiency of either methylmalonyl coenzyme A mutase or propionyl coenzyme A carboxylase. Now, what happens as a result? There's accumulation of their byproducts in this process. Here's a diagram that essentially, shows you everything that's going on. So first, these 4 amino acids, methionine, threonine, isoleucine, and valine, are converted through propionyl coenzyme A mutase, or carboxylase, into methylmalonyl coenzyme A. And then methylmalonyl coenzyme A mutase will then convert these into succinyl-CoA. But a deficiency in either one of these is going to either cause accumulation here, or it's going to cause accumulation here, right? So first, let's talk about propionic acidemia. So your propionyl coenzyme A carboxylase, this enzyme, is deficient, which means there's impaired conversion of propionyl coenzyme A into methylmalonyl coenzyme A. An increase in this will accumulate, and what happens as the cause, it's not converted into methylmalonyl coenzyme A. Instead, it is converted into propionic acid, which then accumulates in the serum and the urine. Now looking at the other one, which is methylmalonic acidemia, here you have a deficiency in methylmalonyl coenzyme A mutase. So when this enzyme is deficient, there is an accumulation of methylmalonic acid or methylmalonic coenzyme A, which is then converted into methylmalonic acid. Either way, they have hyperammonemia, and all these other substances are also accumulating. Coming back to the slide. So deficiency in either enzyme can result in failure to metabolize these and forms produces neonatal ketoacidosis. How do you treat these patients? It's important to give them diets that will prevent further buildup of propionyl coenzyme A. This means following a diet that is low in proteins. So something that's low in isoleucine, methionine, valine, and threonine. And it's also important to avoid odd chain fatty acids. So fatty acids with an odd number of carbons. For example, what do we have? For example, anything that can be converted into acetyl coenzyme A, you want to avoid that. Propionyl coenzyme A, you want to avoid that as well, including cholesterol. Okay, so this is just describing what we already went over. And another aspect to the methylmalonic aciduria is that this enzyme also requires B12 as a cofactor. So sometimes when there is a B12 deficiency, the patients can, can present with similar symptoms. However, you can't treat these patients by giving them more B12 because the enzyme itself is what is deficient. This disease is characterized by a grayish pallor, scaly dermatitis, which just means like itching with scaliness, and hair loss, otherwise known as alopecia. Coming to propionic acidemia, this enzyme requires vitamin B7, but again, supplementing these patients with vitamin B7 does not really, improve their symptoms. Symptoms include poor feeding, vomiting, acidosis, low muscle tone, hypotonia, seizures, and lethargy. This condition, although it's autosomal recessive, it appears to be more common in Saudi Arabia, with the frequency about 1 in 3,000. Okay. This is just another diagram that summarizes what we just covered. Coming to the last one of this lecture, which is homocystinuria. All right, so what is homocystinuria? Homocystinuria, before I talk about this slide, is an inherited genetic disorder characterized by impaired homocysteine metabolism. So impaired metabolism of this substance here. Now, what actually happens? Methionine synthase, so this enzyme, also called homocysteine methyltransferase, methionine synthase is deficient in this disorder. This leads to impaired conversion of homocysteine into methionine, resulting in accumulation of homocysteine. In some cases, in these patients, they may also have cystothionine synthase deficiency. Now, in cystothionine synthase deficiency, there's impaired conversion of homocysteine to cystothionine, again resulting in accumulation of homocysteine. So whether we're talking about a deficiency in this enzyme or a deficiency in this enzyme, ultimately you're blocking off these pathways here. So you're getting homocysteine excess. Homocysteine accumulation is what results in the symptoms of these conditions. All right, so what happens here? Defect in the metabolism of homocysteine causes accumulation of homocysteine, and so these diseases have high urinary and high serum homocysteine levels. Individuals who are homozygous, because remember this is an autosomal recessive disease, individuals who are homozygous will present with dislocation of the lens, sometimes inferior dislocation, skeletal anomalies, so their fingers and sometimes their torso as well is going to be very long and thin. Sometimes these patients can have intellectual disability, and they have an increased risk of thrombosis. They kind of present similar to patients with Marfan syndrome, You know how patients with Marfan syndrome are very thin and tall? Sometimes they have elongated limbs, so really long fingers, arms, increased arm to height ratio. All of these things can, present in patients with homocysteine as well. So it's important to distinguish the features of homocysteinuria from Marfan syndrome. And how do you do that? You do tests. So you can do serum tests or urine tests. Okay, so the more common defect here is actually a deficiency in cystothionine synthase. Remember, there were two enzymes. We were considering either methionine synthase deficiency or cystothionine synthase deficiency, right? So either way, you end up with an accumulation of homocysteine. Now, another important aspect of this is that cystothionine synthase needs a cofactor, vitamin B6. Sometimes in these patients, giving them pyridoxine or vitamin B6 can alleviate some of the features of homocysteinuria. Okay, as for methionine synthase, the coenzymes required here are methyltetrahydrofolate and cobalamin, otherwise known as B12. So a deficiency of this enzyme here will lead to an accumulation of homocysteine. Supplementing these patients, however, with B12 or folate does not really treat these patients. However, in this case, in patients with cystothionine synthase deficiency, if you give them additional B12 and folate, because these are coenzymes required by this enzyme here, sometimes that can improve these patients' symptoms. But essentially, how do you treat them? You give them diets low in methionine, and if these are cystothionine synthase deficient patients, low methionine. Sometimes you can give them B6. All right, coming to a final note on B12 and its importance in inborn errors of metabolism. So B12 is used in two different places that we've covered so far. The first one that we covered was methylmelanin coenzyme A mutase, which was covered earlier. And the second one that we covered was homocysteinuria. So this was organic acidemia here, and then this was homocysteinuria. So what happens is, because of a deficiency in B12, sometimes these unbranched fatty acids will accumulate and accumulate in the brain, different organs in the body, and essentially result in the disorders that you see in these patients. Also, sometimes a deficiency in cobalamin can account for the neurological manifestations of a vitamin B12 deficiency. Why? Because the cofactor itself is deficient. So the activity of these two enzymes is affected as a result. All right, so I have a couple of questions as promised. A couple of questions to end this presentation. So let me read them out for you, and then I'll wait for you guys to answer. An 11-month-old boy is brought to the emergency department by his mother after she observed him having a seizure that morning. His mother reports that the boy is healthy, but he has delayed development. She describes him as a little slow and says that he has required more time to reach milestones as compared to his older brother. The boy appears pale, has light-colored hair, and blue eyes. Which of the following would have most likely prevented this patient's symptoms? Okay, I see a few people saying C, a few people saying D. I'm just gonna give you a minute. Okay, the answer is C, dietary restriction of phenylalanine. Why? Because it's most likely that this patient has phenylketonuria. You can tell by his blonde hair and blue eyes. He is pale, he has light-colored hair and blue eyes. Why? Because of the deficiency in melanin. Tyrosine is not being produced, and because of that, there's a deficiency in melanin, and so this patient has, blue hair, blonde eyes, blue hair, blonde, what am I saying? Blue eyes, blonde hair, and is pale. How do you differentiate this from albinism? Like, what if this patient was just, a patient with albinism? How would I know? In this case, the mom reports that the boy is a little slow. This is attributed to the, the psychomotor delay that this patient has. Because of the, the buildup of phenylketones in his system, in his brain, essentially. This results in intellectual disability and delayed development, delayed milestones, all of that. As for a diet high in phenylalanine, I saw someone say D, that would probably kill the guy. So we don't really want to go there. All right, next question. A 4-year-old boy is brought to the physician for a well child examination. He started walking at 2 years of age. So this is delayed, okay? So right away, he started walking late. Children should start walking by about 12 to 15 months. So he started walking at 2 years of age. He cannot speak. He's above the 99th percentile for height. What does that mean? He's really tall, okay? And he's at the 15th percentile for weight. So he's tall and he's really thin as well. Examination shows bilateral inferior lens dislocation. His fingers are long and slender, and he has a high arched palate. If you guys don't know, a high arched palate is also seen in Marfan syndrome. So right away, off the bat, you know that this patient is presenting with symptoms similar to Marfan syndrome. He has some kind of delayed development, so that probably indicates intellectual disability. What are we thinking? What explains these findings? Again, remember, we're looking for the one that's more common. There could be 2 answers here, but the second answer is not one of the options. Let me just check the chat. Okay, I see everyone saying B. Amazing, perfect. The answer is B. So the patient has a cystothionine synthase deficiency. What is the other enzyme that could be deficient, which could produce similar symptoms in this patient? What could it have been? So we know that it's not cobalamin deficiency, it's not vitamin B6 deficiency, it's not whatever else. What is the other enzyme that could have been deficient? Someone says methionine synthase. That is correct. All right, so someone in the chat said that it could be B or C. So C is vitamin B6 deficiency. While vitamin B6 is necessary for cystothionine synthase, a deficiency in vitamin B6 would not cause all of these symptoms, because these symptoms are caused by accumulation of homocysteine. Do you see the difference here? A simple vitamin B6 deficiency, let's say if cystothionine was there, if homocysteine was not accumulating, a vitamin B6 deficiency would not present like this. This presentation is because of an accumulation in homocysteine. I hope that's clear. To Jenna. Jenna, I hope we're good on that. Okay. Right. I think that's the last slide for this presentation. Oh no, wait. Okay, so this is a summary slide. I'm not going to go over it. You guys can go over it in your own time, inshallah. It's basically covering everything that we did in this whole lecture. So the 2 types of homocysteinuria, you can have cystothionine synthase deficiency or methionine synthase deficiency. For PKD, we're looking at phenylalanine hydroxylase deficiency. What's the other thing that could be deficient here? BH4 could be deficient. So tetrahydrobiopterin deficiency, BH4 could also cause similar symptoms. In albinism, what's the enzyme that's deficient? Tyrosinase. In Alcoptinuria, what is deficient? Homogentisic acid oxidase. Maple syrup urine disease has a deficiency of branched chain keto acid dehydrogenase. And finally, the organic acidemias that we covered for propionyl coenzyme A carboxylase deficiency. You have accumulation of propionic acid. And then in the case of methylmalonyl coenzyme A mutase deficiency, symptoms are going to be the same. You have an accumulation of methylmalonic acid, similar symptoms. Okay, that's it for this lecture, but we still have 2 more to cover. Okay. Let me open the next one. 1 second, guys. Okay, can you guys see? I just opened the Nucleotide Metabolism 1 presentation. Oh, you guys can't see. Okay, let me share again. All right, what about now? Can you guys see now? Yes, perfect. All right, great. One second, guys. Okay, so coming to nucleotide metabolism, I'm not going to go over these. We're going to be going over the de novo synthesis, essentially, of pure nucleotides. Before that, we're going to cover a little bit about what nucleotides are, just like a refresher. And then, yeah, that's basically it. Okay, at the end of this presentation, I didn't get the time to add questions, but I will be asking questions similar to what you should expect in an exam. Okay. Oops. What happened? Okay. All right. So first, going over the structure of nucleic acids. DNA and RNA are polymers of nucleotides. What is a nucleotide and how is it different from a nucleoside? So first, a nucleotide is a sugar, ribose sugar, plus a nitrogenous base, plus a phosphate group. This is what a nucleotide looks like. Here is your phosphate group. Here is the deoxyribose, deoxy because we're looking at a DNA nucleotide, and then a nitrogenous base. It could be adenine, guanine, cytosine, or thymine. So either one of these four, these are all used in DNA synthesis, and this is what a nucleotide looks like. Okay, so again, nucleotide structure. There is the ribose sugar, there is the nitrogenous base, in this case it's cytosine, and a phosphate group. Okay. Why is it stuck? Hold on. Give me a second, guys. What is with her? Okay. Let's start here. All right, so here is a mnemonic kind of to remember which ones are purines versus which ones are pyrimidines. So your purines, there are two, adenine and guanine. And what's different about a purine and a pyrimidine is that purines have two rings in their organic structure, whereas pyrimidines only have one. Now this becomes important later. Why? Because later on, when it comes to the amount of energy that each of these needs, purine metabolism requires more energy or more ATP because two rings are being generated. But pyrimidine metabolism doesn't require as much. Why? Because only one ring is being produced. All right, so here's your mnemonic: pure as gold, pure for purines, and then as gold, A and G for adenine and guanine. Now, if you remember pure as gold, you can just remember that all the others, so cytosine, uracil, and thymine, all of these are pyrimidines. If pure as gold tells you that adenine and guanine are purines, the rest are pyrimidines. All right. Okay, for some reason I cannot change the slide from my controls here, which is weird. Hold on. Why is it not letting me do that? Okay, maybe now. Nope. Nope. So all right, someone told me that there might be some animations on the slides which are more, so I might need to be pressing the arrow keys more. Okay. All right, this is cool. So coming back to the naming, I went over this briefly. earlier, but essentially a nucleoside is a base plus sugar only. Purine nucleosides will end in -sine, so adenosine, guanosine. What does this tell you? Adenosine, the name, tells you that there is this is a nucleoside and not a nucleotide, so there is no phosphate group here. It's only a base and a sugar. So there's adenine plus a sugar giving you adenosine. In this case, guanine plus a sugar giving you guanosine. Now, pyrimidine nucleosides end in -dine or -dine. So thymidine, cytidine, uridine. So uridine, for example, the name tells you that there's a uracil plus a sugar producing uridine. Now for nucleotides, as we covered earlier, it's a base plus a sugar plus a phosphate. So how does the naming change? So now you're getting, because of the phosphate group that you're adding, it's important to indicate that in the name of the product. So earlier you had what was a base and sugar, so adenosine. Now you're adding a phosphate. It becomes 2 phosphate groups. That would make it adenosine diphosphate. If you're adding 3 phosphate groups, that makes adenosine triphosphate, and so on and so forth. Oops. Okay. Ooh, by the way, whoever told me in the chat that I need to press a button more, you were right. All right. Purine and pyrimidine nucleotides can be synthesized in 2 ways. De novo means that the process is occurring from scratch internally, so completely new process, completely new purines and pyrimidines being produced. A salvage pathway, on the other hand, is when cells use, basically they recycle purines or pyrimidines to produce a base, which can then be used again to form a nucleotide. So you can think of these as coming from dying cells or cells that that are now old and are being recycled. These are used in the salvage pathway. About 90% of purines and pyrimidines are salvaged, but those that are not are then excreted as uric acid. And we'll come to that, I think, in the next lecture, inshallah. But yeah, essentially, the salvage pathway comes from a base, and then you add the sugar and phosphate to it, and you end up with the same nucleotide that you started with. Okay, now what is PRPP? So PRPP is a product that is used in both de novo and salvage pathways. And it's used, by the way, for both purine metabolism and for pyrimidine metabolism. Both the de novo synthesis and salvage pathways utilize this sugar intermediate. Now, what is it exactly? So here is the structure of a phosphoribosyl alpha pyrophosphate, or PRPP. Notice how it has 2 phosphate groups. This becomes important later because sometimes these phosphate groups are going to be replaced with other things in the process of producing nucleotides. Okay, so how is PP synthesized? You're starting with a ribose 5-phosphate. So it's a simple sugar with 1 phosphate group on this side. It's a simple sugar, and the enzyme responsible is ribophosphate something kinase, pyrophosphate, yeah, kinase, or something PRPP synthetase, also called. So there's 2 things which either inhibit or activate this enzyme. When there's an excess of unused phosphate, this will cause increased production of PRPP. But when the end product of PRPP is in excess, so you know how this is used in metabolism for producing nucleotides. Let's say the nucleotides are in excess. What does that mean? Essentially, what that means is this pathway, this specific reaction, is going to be inhibited. So you're going to produce less PRPP, so less of it is used. Less of it is used to produce more of the end product. Less end product production, you prevent excess. Again, this is just another diagram explaining where everything is coming from. Ribose 5-phosphate is coming from the HMP shunt. And then PRP synthetase is using that to produce PRPP. Then you're going to go through either the salvage pathway or the de novo pathway, and you're going to end up with nucleotides, which are then used in DNA or RNA, as always. Okay, so here is the de novo purine nucleotide synthesis synthesis pathway. This process has 11 steps, but luckily for us, we only really need to know the rate limiting step. Now, I know that Dr. Henna emphasized this, but I want to re-emphasize it maybe because she asks about this a lot. She is going to ask you what is the rate limiting step for this for purine nucleotide metabolism. Which of the following is the rate limiting enzyme, or whatever. So it's really important that you know exactly what we're talking about. Okay, so let me go back to the slide here. I'm not sure if you guys can see this picture will come again in a few slides. But essentially, we're looking at this enzyme here as the rate limiting enzyme. Glutamine phosphoribosylpyrophosphate aminotransferase. Remember that, okay? So the aminotransferase is a rate limiting enzyme. Okay, so what happens in the de novo synthesis of purine nucleotides? You're starting with the ribose first, which is your sugar here, and then you're adding atoms from the purines. So they're not essentially synthesized as free bases just from the beginning, but you get derivatives from other products, and then eventually that derivative is converted into AMP and GMP. Remember adenosine monophosphate and guanosine monophosphate, okay? Don't forget those terms because I'm going to be saying AMP and GMP a lot. So what's the first purine derivative that you get? The first one is inosine monophosphate, or IMP. You can consider this as like the parent nucleotide, which is then used in the de novo pathway to produce AMP and GMP. What is the base that's attached here? Notice how there's a sugar, then there's a phosphate group, and then there is a base. So what is this base? This base is known as hypoxanthine. So these two things are really important. Inosine monophosphate and hypoxanthine, because these two things are what form the parent nucleotide that can give us adenosine monophosphate and guanosine monophosphate. This is the structure of hypoxanthine. Okay, all right. Now coming to the same diagram that I showed you guys earlier, the first step of this process was actually producing the 5-PRPP, right? That's the first step. Also a very important step, and remember how it had factors that inhibited it and activated it, but that wasn't the rate limiting step. This is actually the rate limiting step of the whole process. And this is also the committed step. So once a product reaches this, that's how you know that this product is definitely going to become either AMP or GMP. Now, what is this step? This step is the production of 5-phosphoribosylamine. Now, what happens here? The PRPP, the phosphate group in the PRPP, is replaced by an amino group coming from the glutamine. So you notice how there's a glutamine, which then becomes a glutamate, and it's leaving with a phosphate group. So clearly it's giving something and it's taking something. A phosphate group is being removed. So what is this side? So these two disappear. You're given an amino group, or the NH2 at the end, and this is known as the rate limiting step. Now, every rate limiting step has factors that inhibit it or factors that activate it. What are the factors that activate this step? The factors activating it are an excess of PRPP. So a lot of phosphoribosyl 1-pyrophosphate is going to cause activation of this step, producing more phosphoribosylamine. But the opposite, let's say there's an increase in AMP, GMP, or IMP. Notice at the very end, IMP is being produced. Too much of either of these, IMP or AMP or GMP, is going to inhibit this rate limiting enzyme. But on the other side, on the other hand, if there's an excess of PRPP in the cell, the enzyme is going to take this as a sign to produce more AMP, GMP, or IMP as a result. Okay, now coming back to the de novo synthesis of purine nucleotides, here are the ingredients essentially that this pathway needs. The atoms that you get in the purine ring can come from 5 different places, but the amino acids that you need to remember are glycine, aspartate, and glutamine. These are the 3 most important amino acids necessary for the synthesis of purine nucleotides. Each of these donates a certain thing to the final nucleotide that is produced. Then, of course, you have tetrahydrofolate and carbon dioxide. Okay, here, next slide. So the enzyme that is transferring the amino group from the glutamine to the 5-PRPP is glutamine phosphoribosylal pyrophosphate aminotransferase, also known as just glutamine PRPP aminotransferase. It's activated by PRPP, inhibited by the end products. We just covered that. Okay. Now coming to the synthesis of phosphoribosylamine. We mentioned that this is the committed and the regulated step. It's inhibited by AMP, GMP, IMP, activated by PRP. It's the same thing we just covered. Okay, moving on. All right, so the synthesis of IMP actually, we mentioned earlier that this is the parent nucleotide. And there's 2 steps in this whole pathway of 11 steps that require something called N10 formal tetrahydrofolate. It's essentially just tetrahydrofolate. But this one is called N10 formal tetrahydrofolate because there's different types of THF. THF can have different groups attached to it. This one specifically is the one with the formal N10 formal tetrahydrofolate. But in various other bodily processes, THF can be present in different various forms. All right, so this pathway requires 4 ATP molecules as an energy source. 4 ATP molecules, so probably what that means is phosphate is being given in various steps of this process. Okay, this is the same slide earlier. Now, how is the IMP actually converted to AMP and GMP? This is a 2-step process. So first, the adenyl succinate is converted to IMP, and then you eventually end up with xanthine monophosphate. Okay, now what actually happens? The first reaction in each of these pathways is inhibited by the end product of this pathway. So for example, IMP being converted to AMP is inhibited by AMP itself. IMP being converted to GMP is inhibited by GMP itself. What does this do? This essentially means that no excess of AMP or GMP is going to be produced. There won't be an excess of AMP because it acts as a negative feedback mechanism. Too much AMP will prevent more IMP from being produced into AMP. Too much GMP will prevent IMP from being produced into GMP. Okay. Another thing to note is that the synthesis of AMP requires GTP as an energy source, whereas the synthesis of GMP requires ATP as an energy source. Now, what's happening here? This guanosine triphos here, and then essentially giving something to be left with GP plus a phosphate. And pretty much same thing is happening. P is giving up something. Another description of the feedback inhibition. When both of these AMP and GMP are present in adequate amounts, the de novo pathway of purine synthesis is turned off at the rate limiting step. Notice how much emphasis is being given to this step because it is very important. She likes to ask things like, okay, what are factors that might be rate limiting factors, might be inhibiting factors of this enzyme? What are activating factors of this enzyme? What is the end product? What is the beginning product, etc. Again, why is it important to stop this pathway at the very beginning? Because you want to prevent production of all the other products in the 11 steps in between. You want to halt this process right here if there is an excess of AMP. Why would you want byproducts lying around? Do you know what I mean? Okay. The next slide, I think, is kind of like a summary. Hold on. Yeah. Okay. So it's essentially telling us what we've just covered. It tells you a good amount of detail on the bases in DNA and RNA. Nucleotides are required for both. Important point to note, thymine is used in DNA, but not in RNA. Uracil is used in RNA, but not in DNA. This step also tells you the 2 places where THF is required. You don't really need to memorize these steps exactly, but it's important that you know that N10 formyl tetrahydrofolate is required in 2 steps in purine metabolism. Okay, now coming to an interesting clinical aspect of this lecture. Here's something called methotrexate. Methotrexate is a chemotherapeutic drug, and it essentially inhibits dihydrofolate reductase. But what is dihydrofolate reductase? Dihydrofolate reductase is the enzyme that converts folate into tetrahydrofolate. Tetrahydrofolate is necessary, as we saw here, in various steps in purine metabolism. So where we don't have tetrahydrofolate, you're not going to be able to produce, AMP or GMP. So these nucleotides are not produced, and that prevents, cell replication. In cancers, that's what happens, right? You have an excess of cell replication. Cells are reproducing too fast. So this drug prevents the production of something that is used in the whole cell replication process. So methotrexate is used to prevent the spread of cancer. It interferes with the synthesis of nucleotides that are needed by rapidly dividing cells. It inhibits the reduction of dihydrofolate to tetrahydrofolate. And so it prevents the production of tetrahydrofolate, essentially meaning that cells are not able to reproduce. Okay. All right, so yeah, methotrexate is used for cancer treatment in several cases. It can also be used for the treatment of rheumatoid arthritis. However, it does have several adverse effects. Now, before we kind of go into thinking of the adverse effects, it's important to understand why this drug has these adverse effects. So we said that it prevents the synthesis of tetrahydrofolate, which is used by cells to reproduce. Which type of cell is going to be most affected? It'll be cells which quickly reproduce, cells which need a lot of tetrahydrofolate. So these cells include your skin cells, which are continuously the cells in your GI tract, which are also reproducing to replace the cells you're continuously reproducing to grow cells, because they're also the cells are rapidly divided most. So that's all you really need to know, that that this drug affects rapidly dividing cells. Okay, now coming to another drug, a sulfonamide. Now what happens in sulfonamides? Sulfonamides are unique because they do not affect human function. They affect function only in bacteria, which actually have this enzyme. So what happens here? Bacteria have this enzyme called dihydropteroate synthase. And it's involved in the synthesis of different, basically folic acid. So sulfonamides compete with this enzyme and essentially inhibit the production of folate, but not in humans, only in bacteria. Someone asked in the previous slide, is RA for rheumatoid arthritis? Yes. Rheumatoid arthritis is another application of methotrexate. Hold on, guys. I've accidentally opened the chat and I can't close it. One sec. Okay, there we go. Apologies. I'm on a new laptop today and it's a struggle. And everything I do is so different from my old laptop. My apologies, guys. If I seem a little slow, it's just because of that. I promise. Okay. I think we're close to the end of this lecture. I think there's only like 3 or 4 slides left. Okay, yeah. So we covered the de novo synthesis, right? Now, what do we need to know about the salvage pathways? Salvage pathway just means that these are, bases that are from recycled things, so increased cell turnover. It can also be from the diet, so proteins that we take in our diet, can also be used for nucleotide synthesis. Okay, so if purine bases are costly for the cell to make, there are pathways to recover these bases in the form of nucleotides. Remember how we're still talking about purines, so we're still talking about adenine and guanine, and hypoxanthine, of course, for the production of IMP, which is necessary for AMP and GMP production. So 90% of purines are salvaged, while 10% are excreted as uric acid. So only 10% of whatever purines we have are actually excreted. I think I mentioned this earlier as well. But yeah, just an interesting thing for you to know. All right, coming to the very end of this lecture, there's two transferase enzymes which are involved in this salvage pathway. There is APRT, otherwise known as adenine phosphoribosyl transferase. Now, this is the enzyme which is used for the salvage of AMP. And then there's hypoxanthine guanine phosphoribosyl transferase. Quite a long name, but again, you can tell that it's to do with the salvage for guanine and hypoxanthine. Now, there's a disorder where one of these enzymes is deficient. That disorder is known as Lesch-Nyhan syndrome. This is Lesch-Nyhan syndrome. Now, what actually happens here? So first, the HGPRT enzyme, what it does, it adds a sugar to guanine hypoxanthine to make them purine nucleotides, right? Let's say if this enzyme was deficient, what would happen? You would have decreased production of GMP and IMP, and an increase in hypoxanthine and guanine. But what are the actual clinical manifestations of this? Because these patients cannot salvage their hypoxanthine and guanine, they're not able to produce enough new ones for their body's needs. But what happens as a result? These patients have a fixed set of symptoms. You can remember them easily by just a few things. One typical thing that is seen in a lot of these patients is self-mutilation. This is a very characteristic feature. Like if you go through this list, there's nothing that stands out more than, for example, this image on this slide. These patients have characteristic self-mutilation. So what they do is they tend to bite their own fingers or their own arms, and it's unexplained why they do that. Scientists think that it may be because of the fact that, there's some accumulation of something in the brain, and that's producing, this self-injurious behavior. But another thing they do is sometimes they might hit their arms against something, or they might hit their head against the wall. This is something these patients do. So right off the bat, that's the first thing I'm going to tell you. Self-mutilation is a characteristic feature of Lesch-Nyhan syndrome. Other features of Lesch-Nyhan syndrome include hyperuricemia, because you have increased production of uric acid. You're not salvaging the purines, so what's happening instead? They're all being converted into uric acid. Therefore, you have hyperuricemia. What else do these patients have? Because of their hyperuricemia, they have gout, because we know that gout is produced by excess uric acid, right? Too much uric acid produces gout. These patients may present with what is known as juvenile gout. So gout at a very young age. Gout usually presents in middle-aged men. You might have really young kids, in this case, presenting with gout. They're also pissed off. This can be attributed to the general irritability from maybe the joint pain that these patients face, or maybe like various other things. It could be anything. It could be also due to, the mental retardation that these patients have. But they're very irritable as well. So the final thing to remember about these patients is they have hypotonia, so muscle weakness. There's a few other things which are not listed here, which are not as important for you to know, but I'll just describe them because they kind of bring the whole picture together. So these patients also have hyperuricemia. So this can also result in, renal failure sometimes. You'll see that their urine has certain crystals which are very specific. for hyperuricemia. It's uncommon for these urinary crystals to be in the urine of kids, but in this case, young children will have it. So what's the typical presentation that you're looking for? This is an X-linked disorder. It doesn't say in your slides here, but it is an X-linked disorder. So what that means is typically these patients will be male. It is X-linked recessive. So these patients are usually going to be male. And what happens is, and this is like the actual presentation, a mom will bring her child to the ER and she'll say, my son has been trying to bite off his own fingers. Like this is what they actually say. They'll say, my son has been trying to bite off his fingers and I can't make him stop. And sometimes they might add something like, my son bangs his head deliberately against the wall and I don't know how to make it stop. And they don't know that what the symptoms of hyperuricemia might be. Some parents might say that my child is slow to understand instructions, something like that, or is very, irritable a lot. These are all just various symptoms of Lesch-Nyhan syndrome. But one thing that is, that you cannot miss essentially is the self-mutilation behavior. That's it for purine metabolism. Do you guys want a break? I think it's prayer time. Do you guys want to pray and then come back before we start the last one? There's just one more lecture left. I would personally prefer to pray and come back. All right. Okay, great. So let's not leave the meeting. I'll leave it running. We'll take maybe 10 minutes. How much time do you guys think should be good? 10, 15? I think, okay, 10 is good. All right, 10 minutes it is. I'll see you guys at 6:55 p.m. inshallah. Okay. Can you guys see? Can you see? Okay, great. Thank you. All right. Okay. So in our last lecture, this one is actually split into two parts. First, we're going to be covering the degradation of the purine nucleotides. So the opposite, essentially, of the process that we just talked about. Then we're going to be covering the production of pyrimidine nucleotides. But both of these are really short, so inshallah, we'll be done pretty soon. Right, okay. So first, the synthesis of, did I skip a slide? No, I didn't, okay. So, yeah. Hold on a second. 1 second, guys. Okay. All right, so we mentioned earlier that ribonucleotides are used in RNA, required for RNA synthesis. Deoxyribonucleotides are required for DNA synthesis. But one important thing to note is, the first thing the body actually produces is, in fact, RNA. So ribonucleotides are produced first, and then they're converted into deoxyribonucleotides. So how is this actually done? So you first start with ribonucleoside diphosphate, and then this is reduced by the enzyme ribonucleotide reductase, and you end up with a deoxyribonucleoside diphosphate. So we don't have triphosphates yet. We're still working with diphosphates. But essentially, this is the enzyme that converts a ribonucleoside to a ribonucleotide. To deoxyribonucleoside. Another important thing to note is this enzyme is inhibited by their end product, which is deoxy ATP, or otherwise known as deoxyadenosine triphosphate. So Again, this is because you don't want an excess of anything. So the end product down the line is going to inhibit the very first step, which produces the very first step in the production of DNA. Okay. So how is the ribonucleotide reductase actually regulated? It's regulated by something called hydroxyurea. So hydroxyurea is a drug that inhibits ribonucleotide reductase. What happens when you inhibit the ribonucleotide reductase? You're basically preventing the production of deoxyribonucleoside diphosphate, this thing here. When you're preventing the production of this, you are preventing the production of DNA, inhibited DNA synthesis. So the cell is not able to reproduce its DNA and cells cannot divide. This is helpful because it's used in conditions where the cells are dividing too much. So it can be used as an anti-cancer drug. It's also used in the treatment of sickle cell disease, because in sickle cell disease, your red blood cells are being destroyed really quickly. So they're also being produced quickly. And so hydroxyurea, controls that, limits that. And anti-neoplastic essentially just means it's an anti-cancer drug. And yeah, that is what happens. If there's an excess of ATP, that will activate the enzyme. If there's an excess of DATP, that will inhibit the enzyme. All right, that's it for the DNA part. Now we're coming to the degradation of purine nucleotides themselves. So we mentioned earlier in the last presentation that all purine nucleotides, when they're degraded, can either be salvaged, so they can be reused to make new nucleotides, or they get converted into uric acid. And in conditions where patients cannot salvage, so patients are not able to salvage hypoxanthine or guanine, that condition was known as Leschnayan syndrome. And that caused an increase in the number of purines being converted into uric acid, because these two things were not being salvaged. So more was being converted into xanthine and more uric acid was being produced, resulting in hyperuricemia and increased uric acid in the urine. Right. So we know the end product of purine degradation, is uric acid. But what actually happens to that? Most of the uric acid enters the blood and is eventually excreted in the urine, as with all other degradation products. So all cells, when they undergo destruction, they produce urea or uric acid. This is important to know. So this applies to literally anything. So if you have like a tumor that's undergoing degradation, that's going to produce uric acid. If there's any cell, an increase in like red blood cells that are being destroyed, like hemolytic anemia, in that case, you'll also have increase in uric acid. Anything and everything that causes an increase in degradation produces more uric acid. Right, now coming to something called gout. What is gout? Gout is characterized by high levels of uric acid in the blood. So an elevated uric acid level. So either there is overproduction of uric acid, too much is being produced. This can be for various reasons. It can be for whatever. It could be because there's overconsumption. It could be because there is maybe a tumor or something that is undergoing tumor lysis and is producing too much urea, or for whatever reason. Or maybe there is a problem with the kidneys and the kidneys are not able to excrete urea. There's under excretion. That can also cause, gout or hyperuricemia in the blood. So in individuals with hyperuricemia, their uric acid under excretion is over 90%. So their uric acid levels in the blood are really high. This leads to crystals being deposited in their joints, deposition of monosodium urate crystals. And there's an inflammatory response to those crystals because it's a foreign object being deposited somewhere. Naturally, the body is going to respond to it. This inflammatory response is known as gout or gouty arthritis in some cases. And it's severe inflammation and pain. It's very painful, quite severe. It's caused by the deposition of these uric acid crystals and the body's reaction to those. So typically, you'll see that these patients are, people who sometimes eat a lot of meat. So for some reason, this disease tends to be more common in males. In the past, this used to be called a rich man's disease because it was associated with an increase in the intake of red meat and fish. So, and it was like thought that rich people only could afford to eat that much red meat. I mean, come on, how are you getting a disease that's only specific to people that are overeating meat? Like you have to be rich for that. I mean, that was like the thought process in the 1800s or whatever. So it was called rich man's disease, and it was in men. So typically what would happen is like a man would go, this happens even right now in the 21st century. So sometimes like, people overeat at like a steak restaurant, for example, too much intake of meat or too much intake of like fish, red meat for whatever reason. They just had a lot. They went out, had a good night out, and then they come home, go to bed, and without realizing, they develop hyperuricemia. So their blood levels of uric acid increase, and they suddenly wake up with severe pain because of arthritis, severe inflammation in a joint. Now, a classic presentation of this is the big toe, the base of the big toe, actually. And that's how these patients will usually present. But it's not specific to the toe. It can also present in, the knee, maybe it can present in sometimes even the thumb. But typically in your exam questions, you're going to see something like a story about this man who eats a lot of meat, goes to bed, and wakes up with a really, really, really painful toe. And first thing you think of is gout. Now, when you analyze, the actual, crystals that are present in the joint, they look something like this. And this is a deposition of monosodium urate crystals. Under polarized light, they look like this. And these are like needle-shaped. I don't know if you guys can tell, but these are needle-shaped crystals, which under polarized light, pink and sometimes yellow, blue. All right. Okay, so how do you treat pain meds? So NSAIDs, right? We know that anti-inflammatory agents such as non-steroidal anti-inflammatory agents, NSAIDs, aspirin, Panadol, maybe even steroids like prednisone. These are all anti-inflammatory agents which can help the treatment of acute attacks of gout. However, let's say a patient has a really high intake of meat, or let's say the patient is not able to excrete enough uric acid. So this is a very long-term condition. Maybe they have renal impairment. Maybe they have some kind of chronic renal kidney disease, something, for whatever reason. They're not able to excrete enough uric acid. These patients are put on something called allopurinol. Now, allopurinol is a non-competitive inhibitor of xanthine oxidase. Xanthine oxidase is the enzyme that converts hypoxanthine and xanthine into uric acid. Hold on, let me just go back a couple of slides here. So this conversion is actually done by xanthine oxidase. Hypoxanthine and guanine are converted into uric acid by xanthine oxidase. Okay, coming back to this. So allopurinol is a non-competitive inhibitor of that. So patients with long-term gout or repeated attacks of gout are put on allopurinol. Other things that these patients can do to avoid attacks of gout, they can avoid diets rich in red meat. So it's really important to change their diets. Dietary and lifestyle modifications can really help reduce the risk of gout flare-ups. And so you specifically want to limit the intake of purines, right? So hypoxanthine, guanine, and adenosine. You want to limit the intake of these things. These things are very particularly present in red meat and like shellfish, seafood. So you want to reduce these. It's also important sometimes to encourage the patients to lose weight, and a few other things. Now, 2 more things or 3 more things that can possibly cause gout attacks. Lower temperatures, it's said that lower temperatures cause uric acid crystals to precipitate more quickly. So for whatever reason, the patient is in some very cold temperatures, this gout attack could be caused by the lower temperatures themselves. Another thing that could cause an attack of gout is exercise. So let's say a person is excessively exercising, they have an excess of lactic acid being produced. Now, lactic acid is filtered out of the body the same way that uric acid is filtered out. Like they compete with the same transporters. So let's say there's an excess in uric acid. There's a lot of uric acid because of excessive exercise. Less uric acid, there's a lot of lactic acid because of excessive exercise. Less uric acid is going to be excreted by the kidneys. There will be an accumulation of uric acid resulting in hyperuricemia, resulting in an attack of gout. Now, one more thing, but this is like very unlikely. Lead poisoning can also cause gout because lead impairs uric acid excretion again, leading to hyperuricemia, and then causing a gout attack. All right, so like we mentioned earlier, gout can be caused in two ways, either by increased urate synthesis. So this is excess of hypoxanthine, xanthine, guanine on this side, or it can be because of decreased excretion. So maybe maybe there's some kind of renal problem that is preventing excretion of uric acid. This can also result in gout. Okay, where do we go? All right, now coming to something called tumor lysis syndrome associated hyperuricemia. Oh, by the way, on this slide, Dr. Hanat wants you guys to know that there's a drug called probenecid. Probenecid is essentially just a drug that acts in the kidneys and prevents excretion of uric acid. So it prevents reabsorption of uric acid, increases excretion of uric acid. It prevents the kidneys from reabsorbing uric acid, so there's more elimination, and is used to treat chronic gout. But this is like a second-line treatment. Your first-line treatment is always going to be allopurinol, which is here, because it is an inhibitor of xanthine oxidase. So it's going to altogether prevent conversion of hypoxanthine and xanthine into uric acid. So this is your standard treatment. In some patients, you might want to use probenecid. All right, now coming to tumor lysis syndrome. Tumor lysis syndrome is exactly what it sounds like. When there's a cancer that is being treated by chemotherapeutic drugs, it results in massive destruction of cells, right? So cells are being destroyed in hundreds of thousands, especially in like leukemia. It can also be any kind of tumor, actually. The cells are being destroyed very quickly. And so there's a chance of hyperuricemia because of increased production of uric acid. There's a lot of other electrolyte disturbances that can also be caused by tumor lysis syndrome, but this lysis of the tumor cells is going to produce an excess of uric acid. This can be a severe complication in patients with cancer. It can be because of any kind of cancer treatment. So chemotherapy, radiotherapy, immunotherapy, whatever it is, ablation, whatever it is, it can result in hyperuricemia. Now, this is kind of like under excretion problem. So the body's not able to remove the uric acid excess quickly enough. And this results in hyperuricemia because of the increased catabolism of purine nucleotides. Excessive production because of destroying cells, the body's not able to excrete it quickly enough, results in hyperuricemia. And then, of course, other implications. Okay, coming to defects in purine metabolism. Where are we? Okay. So here's something called adenosine deaminase deficiency, ADA deficiency. This ADA deficiency is important in the conversion of adenosine into inosine. So what happens here? An amino group is being removed from AMP. Hold on one second, guys. Okay, an amino group is being removed from AMP to produce IMP first, and then this is done by the AMP deaminase. Then it can also be done from conversion of adenosine directly to produce inosine. And it's the same enzyme, or it's the same, it's a deaminase still being, being used here. Now, what happens in adenosine deaminase deficiency? So adenosine deaminase, otherwise known as ADA, is present, everywhere in the body, most prevalent in lymphocytes. And what happens is accumulation of adenosine occurs in deficiency of this enzyme. Deficiency of this enzyme means adenosine is not being converted into inosine, so we're not able to kind of essentially, reuse any of these products. Deficiency of this enzyme can cause severe implications in lymphocytes specifically. So we're talking about things like T cell, B cell depletion, lymphocytopenia, SCID as well, which is known as severe combined immunodeficiency. This deficiency results in all of these things. And because these patients have such severe implications, especially in their lymphocytes, so their immune cells are affected most, they have very poor immunity. They have, immunosuppression, if you will. And so these patients are very susceptible to illnesses. And a lot of these children die before 2 years of age because of infection. So because of this deficiency, essentially, they have a decrease in the number of T cells and B cells and even NK cells. So all the cells that fight infection are decreased. And the only treatment in these patients would be to completely replace them with new cells. So bone marrow transplantation or stem cell therapy, or maybe you can also give these children enzyme therapy. So replace the deficient enzyme in these patients. However, without these replacements and treatments, these patients will most likely die of infection before the age of 2. All right, so here's what we've already covered on the purine side. Now we're coming close to our pyrimidine synthesis part of this lecture. So this is a pyrimidine. How are these synthesized? They're synthesized first before being added to PRPP. Remember in purine synthesis, there was a purine that was synthesized on the PRPP. Like PRPP was your starting product, and IMP was what was the parent nucleotide, and then you generated GMP and AMP. On this end, you're synthesizing first, and then you're adding on to PRP. And this is regulated by UTP, which is again a end product of the whole process. I was going to say something. Yeah, okay. That's all. All right, also both processes require energy, but pyrimidine synthesis requires less energy because again, all these pyrimidines have only a single ring, whereas the purines have double rings. All right, so synthesis of pyrimidine ribonucleotides. Like I mentioned earlier, the base is what is made first. Then it is attached to the ribose phosphate. So it's the opposite of purine biosynthesis. In this case, it only requires 2 precursors. Previously in purine synthesis, we needed a lot of products. We needed 3 different amino acids. We needed tetrahydrofolate and we needed carbon dioxide. In this case, we have only aspartic acid and glutamine plus CO2. And you're ending up with a 6-membered ring. Pathway is shorter, only 6 steps, and the product is UMP in this case. UMP is your parent nucleotide. It is what can be used to form CMP and TMP, right? If you guys have any questions, by the way, please feel free to ask as I go along. Okay, right. Now, what is the rate-limiting enzyme here? Or what is the main enzyme, the star of the show? This enzyme is known as carbamoyl phosphate synthetase. Specifically, carbamoyl phosphate synthetase 2. There's different kinds of carbamoyl phosphate synthetase. There is a CPS1, which is present in the mitochondria, and that is used for the urea cycle. If you guys haven't done the urea cycle lecture yet, definitely recommend going over that or going over it just so you understand what the function of CPS1 is. CPS2, on the other hand, is used in the pyrimidine synthesis process. So, yeah, okay. And of course, it is the rate limiting step. So UTP inhibits CPS1. UTP is the end product, right? End product inhibition again is taking place here. UTP is inhibiting CPS1. So it's important to understand the differences between CPS1 or carbamoyl phosphate 1 and CPS2, carbamoyl phosphate 2. So both of these enzymes have similar functions, but they are very different in terms of where they're located, what they're doing, wherever they're located, etc. On this side is the function of CPS1 in the mitochondria. And this is just a table comparing the two. I'm going to let you guys go over this in your own time. I would go over it, but I don't think we have too much time. I promise to end this lecture by maybe 7:30. But essentially know the difference as well. She might ask you about them. I don't think she does actually. But it's important to know the activities of both. She's not going to really ask you to compare CPS1 and CPS2 though. Okay. Now, de novo pyrimidine synthesis. What are we talking about here? Carbamoyl phosphate is your starting step here, carbamoyl phosphate, and it is being converted into carbamoyl aspartate. But this is your, regulating step essentially. And after you get carbamoyl aspartate, it is converted into all these other things. You actually end up with UMP, and UMP is then converted into CMP and TMP. But an important thing to consider here is something called orotic aciduria. Now, what is orotic aciduria? It is caused by a deficiency in the UMP synthase enzyme. So essentially the enzyme that catalyzes these two reactions. All right, so in this case, you have OMP, which is orotidine monophosphate. It's converted into UMP, uridine monophosphate. And this is the first pyrimidine that you're getting. I think the next slide. Yeah, okay. All right, so a deficiency in either one of these can lead to orotic aciduria. What happens is orotic acid accumulates in the blood, and also it will be present in the urine. So you have both orotic acidemia and orotic aciduria. Okay, we'll cover that in more detail in a few slides. But coming to the formation of an actual, pyrimidine nucleotide, what happens here? The completed pyrimidine ring in orotic acid is converted into UMP using UMP synthase, as we saw in the previous slide. A deficiency in this UMP synthase causes orotic aciduria, which is a rare genetic defect, and it results in orotic acid in the urine. This is treated by giving uridine. How does uridine treat this disorder? Because essentially you're skipping the steps which require these enzymes. Let me go back. Or actually, there's no need to go back. Essentially, the steps that are being inhibited by this deficiency, that are being stopped by this deficiency UMP synthase, can be overcome simply by giving the patient uridine. Let's go back here. So by giving the patient uridine, they will directly be able to produce UMP, overcome these two steps. So there won't be a need for the UMP synthase enzyme. So it's relatively treatable with uridine. Uridine treatment is very effective because the uridine directly is converted into UMP by the kinases, and that will, allow production of CTP and TMP. And then everything else continues as normal. Okay. Now coming to thiamidylate synthase and its conversion of DUMP into DTMP. So now we're going from the parent nucleotide into the one that we want, which is TMP. Tetrahydrofolate is needed for this process. You're converting the U into a T, basically, essentially, as Dr. Annette mentioned. And this methyl group is coming from the N5, N10 tetrahydrofolate, methylene tetrahydrofolate. This enzyme is thiamidylate synthase that does this process, and it is targeted by an anti-cancer drug called 5-fluorouracil. What does 5-fluorouracil do? Prevents the conversion of DUMP into DTMP. So another important aspect is this tetrahydrofolate also requires dehydrofolate reductase. Remember we covered this in the previous lecture. The hydrofolate reductase is targeted by methotrexate, which prevents the conversion of folate into tetrahydrofolate. So this whole process actually can be affected by both drugs, 5-fluorouracil and methotrexate. Both of these are anti-cancer drugs, but they act in different forms, different places, basically. Okay, in different ways, if you will. Here's another diagram showing you how 5-fluorouracil acts. And there's two drugs that will affect this step. Methotrexate acts over here. 5-fluorouracil acts over here. Methotrexate is preventing the conversion of dihydrofolate into tetrahydrofolate, whereas 5-fluorouracil is preventing the conversion of DUMP into DTMP. And that's just an image showing you the drugs. Okay. This slide is basically describing the need for folic acid in converting these products into TMP, which is your final thing. So it's needed to convert DUMP into thymidine monophosphate, and this form is called N5N10 methylene. Earlier in purine synthesis, we covered N10 formal THF for purine synthesis. In this case, we're looking at N5N10. So just a small difference is for you to keep in mind. Okay. This is a summary slide that describes all the various drugs. Someone said in the chat, they're both affecting the same reaction but different parts. Exactly. Now methotrexate, you can kind of think of it as the one drug that affects both purine synthesis and pyrimidine synthesis. Because remember how earlier it was also affecting, hold on, actually, where's the slide? That slide shows it really well. The one before this. Yes, here. So all of these processes are processes that need tetrahydrofolic acid or tetrahydrofolate. Oops. N10 formal THF was used in purine synthesis. So methotrexate again prevents the production of this. In thymidine synthesis, again methotrexate prevents this formation. So it's acting in both pyrimidine and purine synthesis. 5-fluorouracil, though, however, is only preventing the conversion of DUMP into DTMP, whereas methotrexate kind of has a more general effect, if you will. But yes, they are both anti-cancer drugs targeting the formation of purines and pyrimidines. Now, what do you need to know in this lecture? Let me just quickly go over it from the very top. You need to know how they're synthesized. What enzyme makes it a deoxyribonucleoside? You need to know that. It is a ribonucleoside reductase. The action of hydroxyurea, it is a chemotherapeutic drug. You need to know how it acts. It prevents the conversion of ribonucleosides into deoxyribonucleosides. Okay, great. Over here, the mechanism behind gout, very important, must know. The drugs used, so allopurinol, you need to know that. You need to know the foods that cause increased risk of gout. Those are important. TLS-associated hyperuricemia, just understand the concept. The defects in purine metabolism. ADA deficiency, very important. You need to understand where and how this causes an effect. There's a lack of T cells and B cells and NK cells. That's what happens in this disease. As for here, it's important to understand the regulating step. Know it, know the regulating step here, know the enzymes, know the differences between CPS1 and CPS2. And again, know the mechanism behind orotic aciduria. How do they treat it? Important to know, okay? Also 5-fluorouracil mechanism of action, and that is pretty much it. And then this is the final summary slide. Also know the action of sulfonamides, but remember that sulfonamides do not have any action in human cells. They only affect bacterial cells. That is it. This is basically a summary from everything that we took in the last lecture and this lecture, all the drugs. And that concludes our 3 lectures of today. I know I kind of sped through them. I hope things were clear for you guys, inshallah, and all the best for your biochemistry final. I think it's your last exam of year 1, maybe? Is it? I'm not sure. But good luck, you guys. Allah yuwaffiqkum, inshallah, will be easy. Oh, you still have genetics. Genetics is like 2 days after biochemistry, I think. So someone told me, I can't, yeah, I think it's 2 or 3 days, inshallah. Oh, also random, but one thing about genetics, study it well, because although the course is easy, but his exams tend to be kind of tight on the number of MCQs that he gives. So for example, the percentage the exam is worth will be like 60, 70%, something like that. And his MCQs will be like 60 MCQs. So every question you get wrong has a lot of points, basically. That's what I'm trying to say. So make sure you study well for it, you guys. But right now, focus on biochemistry. Inshallah, it will be easy, inshallah, ya Rab. And then you won't have to do biochemistry ever again. You'll do it occasionally, but very, very little. Never like this, inshallah. All the best, you guys, and good luck. I think we have another session, so I think, do I leave this meeting or I don't know? I think I should leave it, yeah? Bye, guys. Good luck.